Hi, everybody. Thanks so much for joining us on this Thursday evening. So I am Sunandana, or Sue Chandra. I'm one of our melanoma medical oncologists, and I've been tasked to go over some interesting, some complex ideas that I hope will give you an appreciation for what types of drugs we use for advanced cancer, why we use them, and what challenges we face. So, I'm on the clinical advisory board for a few companies. So Sir William Osler, he was a physician in the late 1800s, and he said, if it were not for the great variability among individuals, medicine might as well be a science and not an art. And to this day, we still say that we practice medicine. And interestingly enough, Dr. Osler was the first person to start residency programs. So he's one of our forefathers. So melanoma has been in the media quite a bit. It's been in a lot of non-medical journals. I often have many of you come into our clinic appointments saying, Sue, have you read this article? What does this mean? And I want to take some time to try to explain why it's gotten so much hype. Some points we'll be going over today is some brief background. I'd like to briefly tell you about our current approved therapies for advanced melanoma, the challenges that we face, what do we mean when we say personalized medicine, and finally, what future therapeutic options are on the horizon. So I'm not going to belabor this, but as many of my colleagues had stated, the majority of melanomas are cutaneous or skin, about 90% or so. You have acral, which is the subtype of skin melanoma on the palms of your hands and the soles of your feet. And the reason we kind of put them in a different category is, as you can imagine, they don't really see a lot of sun exposure, so their biology is very different. We have mucosal melanoma, where they develop in the sinonasal passages, the gastrointestinal tract, and the vulvovaginal tract in women. And then finally, we have uveal or ocular melanoma. But the majority of our data is actually all from the cutaneous population. So you do not need to memorize this graph, but I wanted to show you the drugs that we have currently approved for advanced melanoma. When I say advanced melanoma, I mean melanoma that's either gone to the lymph node or to a distant organ. Now, the word adjuvant may come up quite a bit. All adjuvant means is that the melanoma has been surgically removed. So generally, we mean stage 3 melanoma. Sometimes in a select group of patients, you can have a stage 4 metastatic melanoma, maybe with one metastatic lesion which has been removed, which we then still call adjuvant melanoma. And then finally, metastatic melanoma, which we all know is when it's traveled to a distant organ. So as you can see, since the vast majority of these drugs are in blue and green, and the majority of them have actually been all approved since 2011. So the past 5 years has been groundbreaking for not only melanoma, but cancer in general, and melanoma has really been in the forefront of that, and I'll go into detail as to why. The blue and green, the blue are basically all the immunotherapies that have been approved for melanoma, and the green are the targeted therapies that have been approved for melanoma. As you recall, or as you may recall, Dr. Garami had mentioned the BRAF mutation. About 40 to 50% of melanoma tumors have a BRAF mutation. And if a tumor has a BRAF mutation, in addition to the blue immunotherapies, we can also use the green targeted therapies for those patients. Okay, so why is melanoma a poster child for immunotherapy? So if nothing else, I hope I can kind of explain to you the importance of this figure, and I hope that this kind of makes sense to you by the end of the evening. So this is called the cancer immunity cycle. Even if you can't read it, if I could just walk you through it. So on the bottom is our melanoma tumor. Okay, the melanoma tumor just naturally sheds a lot of melanoma proteins, which we also call antigens. Those melanoma proteins are taken up by special immune cells called antigen-presenting cells, one of which are called dendritic cells. Those antigen-presenting cells take up these melanoma proteins or antigens. They kind of express them, kind of like a badge of honor, if you will. They then travel to lymph nodes, and in the lymph nodes, those antigen-presenting cells carrying your own melanoma tumor proteins activate a different type of immune cell. They're called T cells. They're basically your soldier immune cells. Those soldier immune cells then basically leave your lymph nodes. They travel through our bloodstream. They then identify those melanoma cells that may be hanging around no matter where they are, and then they kill them. So that's how our immune system works when it does work, okay? Now, at various points in this cancer immunity cycle, we try to make it work even better. How do we do that? So we use chemotherapy, radiation, targeted therapy to kill the melanoma tumor cells so they shed more melanoma proteins. We use vaccines, interferon, a drug called GM-CSF, to make those antigen-presenting cells work even better. We use IL-2 or the anti-CTLA-4 antibody, which is Yervoy or Ipilimumab, to make those T cells in the lymph node remain active. We then use PD-1 drugs such as nivolumab or Opdivo or pembrolizumab or Keytruda to make the tumor cells not be able to shut down those soldier immune cells. Okay, so it gets a little bit complicated as you can see. So what are our current approved therapies? So for this adjuvant setting, we have first and foremost a clinical trial, interferon, and high-dose ipilimumab. For our metastatic setting, we have a few more options, a clinical trial if we have one, IL-2, ipilimumab or Yervoy, nivolumab or Opdivo, ipilimumab and nivolumab combined together, pembrolizumab or Keytruda, and telimagene laherparivec or TVEC, which is kind of a mouthful. So let's go over these in a little bit greater detail. So in the adjuvant setting, what are our options? Option number one is close surveillance. What does that mean? That means come into your clinic visits with your dermatologist, surgical oncologist, your medical oncologist, frequent visits, some lab tests, some scans, and you do that for a period of time to try to, again, detect any melanomas that may be recurring or even any new melanomas that might pop up. Option number two is interferon. Interferon's a tough drug. Many of you may have experienced it. So it's a drug that's given for up to a year, and that's the most common one, although we do have a different type of interferon that can be given up to 5 years. And that it's got a 10% 5-year relapse-free survival. You might ask, well, what does that mean? So if you compare two patients, one who got interferon and one who didn't, and if you fast forward 5 years, the one who got interferon may see a 10% improvement in their recurrence risk. So that number isn't great. You know, if that was 90%, it would be a much easier discussion. But 10%, it makes it a little bit challenging. Furthermore, there are some toxicities that are associated with it. It can damage our livers, fatigue, it can cause muscle pain, depression. It can even increase thoughts of suicide. So in patients with a history of depression or anxiety, we're very careful about recommending this drug. Third option, high-dose ipilimumab. As you can see, the 5-year relapse-free or recurrence-free survival, a little bit better than interferon. But again, we still see toxicities. It can affect our gastrointestinal tract, our liver, as well as our different endocrine glands like our thyroid, pituitary, adrenal glands, etc. And finally, option number 4 is a clinical trial if we have one. We happen to have 2 clinical trials here at Northwestern. One is the SWOG 1404 trial. One is the vaccine trial. So let's go over those in just a little bit of detail. So the SWOG trial, a person must have stage 3A, B, or C disease, or a resected stage 4 disease. They sign informed consent, they're enrolled into a trial, and then they're randomized. The SWOG group does the randomization. Unfortunately, I have no say, but the patient is randomized to either receiving Ipilimumab or interferon, and that's based on our discussion with the patient and what we think is safest for the patient, versus the study drug, which is pembrolizumab or Keytruda. So you might be wondering, well, why did they choose Keytruda? Why pembro? So in the metastatic setting, again, this is the adjuvant setting, but in the metastatic setting, pembro has actually shown to improve survival. So the way medicine works is I can't just give it to you. I have to be able to prove that when we compare it with our currently approved drugs of Ipi or interferon, it is just as good, if not better, okay? And then our adjuvant trial number 2 is the vaccine trial. So this trial, some of you are on, it's got 2 components. One is someone must have resectable melanoma, enough tissue where a vaccine can actually be prepared from it. So Dr. Jeff Wayne, Dr. Carl Villamoria will take you to the OR, remove the melanoma tissue, we'll send it off to a company called Ilios Therapeutics in the Carolinas. Step number 1. The company basically chops up your tumor, we call that tumor lysis, and produces a lot of tumor antigens. Step number 2 is about 4 to 6 weeks after your surgery. We draw some blood. We send that blood to the same company. They then extract your immune cells from the blood and then mix the 2 together to make a vaccine. Now, the tricky thing is it's a randomized trial, so you have a 66% chance of getting that vaccine, which is your own immune cells loaded with your own tumor proteins or antigens, versus just your own immune cells with nothing loaded onto them. And it's double-blinded, which means I won't know what you're getting, you won't know what you're getting. And only at the end of the trial, or if for some reason I have to take you off the trial, that's when we'll know. But the vaccines are given over a period of 18 months. And again, both the SWOG and the vaccine trial, the whole purpose of it is to try to decrease the risk of your melanoma from coming back. So, what's immunotherapy? How does it work? It's been all over the media. Mark Harmon, the famous medical oncologist, also the lead detective in NCIS, used the PSA, I am my own secret weapon, and that's kind of how immunotherapy works. So let's kind of parse this down. So how does Ipi or Yervoy work? So you have your antigen-presenting cell in purple, okay? Remember, it takes up the tumor protein, it takes up the melanoma tumor protein and shows it to this T cell in the lymph node, and it activates that T cell. That activated T cell can then travel throughout your body, identify any melanoma cells, and kill it. That's how it's supposed to work. But evolutionarily, our bodies have developed checks and balances. So when you have an activated T cell, this orange receptor called CTLA4 becomes expressed. That then shuts down the T cell. So in the world of cancer, we don't want that. We want that T cell to remain active. And so that's where Ipilimumab or Yervoy comes into play. It basically binds that CTLA4 receptor, thereby keeping the T cell active, okay? That's the basic premise of immunotherapy. The CTLA4 receptor is just one example of an immunotherapeutic target. Similarly, PD-1 works in a similar fashion, just on a different receptor, in a different location of that cancer immunity cycle. So when that, if you recall from our earlier discussion, when that active T cell goes back to locate any melanoma cells, the melanoma tumors actually have molecules on them that shut down those soldier T cells, preventing them from killing the tumors. And that's how Nivo and Pembro work. They basically prevent the melanoma tumor cell from shutting down the active T cell. So let's see an example. This is a patient of mine who graciously allowed me to use her scan. So let's orient herself. So this is a patient who is lying on her back. This is the back, this is the chest, this is the left, this is the right. This black stuff right here this is the left lung, this is the right lung, this is the heart, the great vessels, lymph nodes in the center. If you can see, this lymph nodal mass went from this size to this size after only 3 months of Opdivo or nivolumab therapy. This liver tumor, same patient, liver, this is the liver. These 2 liver lesions went from these sizes to this size, and one of them actually completely disappeared. So when these drugs work, they really work well. What's the concept of pseudoprogression? These drugs do work a little bit strangely sometimes. If you look at this patient's baseline scans, you'll see all these gray circles. Those are subcutaneous melanoma tumors that should not be there. 3 weeks later, we happen to scan them for another reason. If you see, these gray circles have actually gotten a little bit bigger. So one might say, oh gosh, the immunotherapy is not working. But we kept the patient on the drug, and lo and behold, 4 months later, they've almost completely disappeared. So this interim interval progression, we call it pseudoprogression. We think it's because the immune cells infiltrate the tumor, cause them to become more puffy, more inflamed, and so they look bigger on scans. So sometimes it's not always the case. Sometimes, unfortunately, it is true progression, but pseudoprogression is a real phenomenon with immunotherapy that we have to deal with. So back to the cancer immunity cycle. We've talked about how Ipi affects the antigen-presenting cell in the lymph node. We talked about how Nivo and Pembro affects the melanoma cell from deactivating the soldier T cell. So then you might ask, well, Sue, why not just combine them? And in fact, we did. So when we combine them, we see in this fancy graph, so let's step back for a second. So this is a group of patients who just got Nivo alone in this trial, nivolumab plus Ipilimumab alone, and Ipilimumab or Ipi alone. And as you can see, each of these lines is a single patient and their tumor response. The more downward lines, that means more patient had decreased tumors, versus the more upward lines show that the tumors actually increased. And just from a glance, you can tell that the Nivo-Ipi arm patients had much more decreases in their tumor sizes, which is great. That actually translated into bigger progression-free survival, meaning that there was no progression for a number of months in that combination group that was greater than either drug alone. But unfortunately, we don't get something for nothing. So high-grade side effects in that combination group was also significantly higher. So CTLA-4 and PD-1 are just 2 inhibitory receptors that shut down the T cells. There's a bunch more that we're starting to find out about. There's a lot more activating receptors that activate T cells. So all of these are in clinical trials. So I think we've really reached the tip of the iceberg with respect to immunotherapy. So you might ask, well, what's so special about melanoma? What makes it work so well with immunotherapy, whereas many cancers don't? If you remember Dr. Garami's talk, he talked about somatic mutations. So these are mutations specific to a melanoma tumor. These are not mutations that you can pass on to your children. If you look at this graph, melanoma has the highest mutation burden of all these cancers. These include breast, hematologic cancers, lung cancers, kidney cancers. Of all of these, melanoma has the highest. So how does this translate? So we think that the higher number of mutations, that means more melanoma tumor antigens are present, more potential to show those antigens to those antigen-presenting cells, more chance to basically activate our immune system. Problem is, immunity is a fine balance. So we're trying to control the cancer, but these immunotherapies, when they activate your T cells, they're also affecting your healthy cells. And the way that manifests is your healthy cells start developing autoimmune type side effects. So what do we mean by that? So the suffix itis, I-T-I-S, means inflammation. So any kind of itis you can think of, you can get with these immunotherapy drugs. For an example, dermatitis or rash. It's just inflammation that you can get on any part of your body. Many of you know, when you come to my clinic, I check your skin, I ask, has there been rash, has there been itching? This is the reason. We do not want it to get to this point. Colitis manifests as diarrhea. It's when your colon's inflamed. This is a person who received immunotherapy. All these white patches on his colonoscopy that I had to send him to because of diarrhea that I just couldn't get a handle on, all those white patches should not be there. That's colitis from the immunotherapy. So let's shift gears for a little bit. Dr. Garami mentioned the BRAF mutation. Again, 40 to 50% of melanoma tumors have a BRAF mutation. When that mutation's present, this signaling pathway is really active. We call it constitutively active. It's always active. So let's orient ourselves. This is the cell wall. This is the lipid phospholipid. It's basically our cell membrane. This growth factor receptor basically activates this RAS pathway. Normally, this RAS pathway is not always active, but when we have a BRAF mutation, it's always active. And that basically causes melanoma tumor cells to be able to divide and survive, and that's not what we want. So these targeted therapies, such as the BRAF inhibitors, vemurafenib or dabrafenib, or the MEK inhibitors, trametinib or cobimetinib, are used to block this pathway, stop it in its tracks, and shrink the tumors. And here's an example of how they work. So these are 4 patients. This is a PET scan. And so so the black circle on top, that's the brain. It's active, it's always active. That's why it's just lit up on the PET scan. But all of these black globs and dots on the left side of each patient, those are melanoma tumors. And after only almost just a little over 2 weeks of BRAF targeted therapy, look at how much in each patient the tumors shrank. It's significant. This is a patient of mine who came in 10 years after his initial melanoma on his chest with a 5-centimeter lump in his throat. So Dr. Wayne sent him to me. He happened to have a BRAF mutation, so we treated him with BRAF targeting drugs for 8 weeks. 8 weeks later, this is how his neck looked. Completely flattened. The little bit of darkness in his chest is just a side effect from the drug. Now, if you're queasy after dinner, I would probably avert your eyes. So Dr. Wayne took this patient to the operating room, removed the tumor, and under the microscope, the pathology showed no more melanoma cells left. So that 8-week, what we call neoadjuvant therapy, meaning therapy prior to surgery, essentially rendered this patient melanoma-free. Some of you are on a drug called T-VEC. It's a pretty newly approved drug. It's a modified virus. It's a herpes virus that actually only infects melanoma cells, not healthy cells. It infects melanoma cells, it reproduces in the melanoma cells, it kills the melanoma cells. The melanoma cells then shed a lot of tumor antigens or tumor proteins, which then basically attract immune cells to then do their job and kill the cancer. So what we know so far is the tip of the iceberg. We talked about the BRAF pathway. That's just to show you, that's just this pathway right here. And this is just a snapshot of so many molecules in our cell that we are just slowly starting to understand on whether they activate our cancers, whether they keep our cancer cells from dying, whether they keep them, alive and kicking. So these are all potential targets that we are slowly starting to look at. So how do we address this? So in addition to the BRAF target, we do something called next-generation sequencing here. So we send a person's metastatic melanoma tissue to Foundation Medicine, which is a company. They do fancy DNA sequencing on the tissue to then give us a 20 or 25-page report saying, Sue, this is your patient's DNA mutation report. And based on that, in addition to BRAF, NF, NRAS that Dr. Gramia talked about, there's other mutations that we could potentially target on clinical trials, et cetera. So we have a number of current and upcoming trials here at Northwestern. For stage 3, we have the SWOG and the vaccine trial, like we talked about. In the metastatic melanoma trials, we're looking at, can we add third or fourth agents to the BRAF and MEK inhibitor targeting drugs? Can we add other agents to Ipi or Nivo or Pembro? Can we add agents to TVEC? For uveal or mucosal melanoma, we have some specific trials. And then finally, we have some phase 1 and 2 trials looking at all those other pathways that I mentioned. So I hope I was able to give you a flavor for where we are with respect to our advanced melanoma treatment options, the challenges, and really give you a sense of how these immunotherapies and targeted therapies works. So the next time you're at a dinner, cocktail dinner, you can, wow all your friends with your knowledge. Thanks.